In this lecture, we are going to discuss polycythemia. What are the clinical features of the polycythemia? What are the causes of the polycythemia? The polycythemia can be secondary or it can be primary. The primary polycythemia is one of the myeloproliferative disorders, the other being essential thrombocytosis, chronic myeloid leukemia, and myelofibrosis with myeloid metaplasia. Now, what are the clinical features of polycythemia? If the hematocrit is more than 48% in females and more than 49% in males, this is polycythemia. Polycythemia itself produces some general common features irrespective of the cause of the polycythemia. They are because of the hyperviscosity and sluggish blood flow. They can be fatigue, headache, dizziness, vertigo, tinnitus, visual disturbances, confusion, lethargy, chest pain, muscle pains and ache, episodes of thrombosis in various places, venous thrombosis, even on arterial side, patient may have bleeding particularly from the nose, patient may appear flushed on the face, and polycythemia in patients who got secondary polycythemia sometimes may be asymptomatic. Now, what are the causes of secondary polycythemia? Maybe respiratory diseases like chronic obstructive airway disease, the pulmonary fibrosis, sleep apnea, extreme obesity that can produce hypoventilation, cardiac, that means right to left shunts, for example, Fallot's tetralogy or Eisenmenger complex, they can produce polycythemia. Smoking, high altitudes produce physiological polycythemia, anabolic steroids, tumors which secrete erythropoietin, for example, renal cell carcinoma, hepatocellular carcinoma, cerebellar hemangioblastoma, parathyroid carcinoma, even parathyroid adenoma can do it, pheochromocytoma, meningioma, they can all produce erythropoietin and cause polycythemia. Then renal disease like polycystic kidney disease, hydronephrosis, renal artery stenosis, they can do it. And then high affinity hemoglobins and familial polycythemia, which are not very common happenings. And then there are rare chromosomal abnormalities which can cause polycythemia. For example, you can see polycythemia in von Hippel-Lindau disorder. And then you got primary polycythemia. Primary polycythemia or polycythemia rubra vera is a clonal disorder. It can produce certain symptoms other than the symptoms produced by the polycythemia. So there may be night sweats, there may be weight loss, there may be joint pains, there may be itching after hot bath, there may be erythromelalgia. The hands and the feet, they may become very red and have a lot of burning, and there may be pain. So this may be present in polycythemia. There's fullness in the upper abdomen, face is ruddy in appearance, and the patient may have splenomegaly. Now, how we define polycythemia vera? Polycythemia vera has certain major criteria and a minor criteria. All three major criteria present, or two major criteria, one minor criteria present. It is polycythemia vera. The major criteria include the hemoglobin or hematocrit in men over 16.5 or 49%, while same corresponding values for female are 16 gram per deciliter or 48%. There is increased red cell mass, that is 25% above mean normal for the predicted value. And then prominent erythroid, granulocyte, megakaryocyte proliferation in the bone marrow with pleomorphic mature megakaryocytes. There may be presence of JAK2 mutation. This may be V617F or JAK2 mutation exon 12. So either of this may be present. And the minor criteria is there is subnormal erythropoietin. So if all three are present, this is polycythemia vera. If two major and the minor criteria are present, this is a case of polycythemia vera. Now, when you get a patient with polycythemia, you get CBC and blood smear, very important. That tells you the cell morphology. Generally, it is normocytic, normochromic type of cells. Check for erythropoietin. It is erythropoietin is low or is high. Check for the renal function test. Look at the LFTs, how are they, iron studies. Many patients with polycythemia vera may be iron deficient. Uric acid, LDH, they may be increased in patients who got myeloproliferative disorder. Transcobalamin 3 is increased in patients who got polycythemia vera. So vitamin B12 level may be falsely high. Check for the presence of hypoxia. Go for pulmonary function testing to see how much is the obstructive or restrictive defect. Carboxyhemoglobin may be tested for patients who are smoker. Then JAK2 mutation testing, as I mentioned, in two types of mutations are present, so they should be tested. For definition, we may require bone marrow examination. Abdominal ultrasound, chest X-ray, whole body CT to look for the secondary causes of polycythemia vera, and then sleep studies. When you get a patient with polycythemia vera, identify avoid and treat the underlying cause. If possible, so treat the underlying causes. Phlebotomy to keep the hematocrit less than 45% in the males and less than 42% in the females. Low dose aspirin, 100 mg of acetylsalicylic acid should be added daily to prevent thrombosis. Then cytoreduction therapies like hydroxyurea or interferon-based treatment for younger and patients who are pregnant. Then ruxolitinib may be used with patients who got polycythemia vera. Anagrelide, busulfan, imatinib have also been used for this. And then antihistamines and SSRIs may be used for itching. So these are the different treatment used for patients who got polycythemia vera.